opportunity to reach out to the public.
Okay.
तिवारी जी,
Yes, sir.
आपकी डबल हेलिकल मैगजीन को 10 साल हो चुके हैं।
Yes, sir. Yes, sir.
तो आपने 10 साल का सेलिब्रेशन क्यों नहीं किया?
अब बताएं सर कब करना है सर? Whenever you want, we are ready. No issue.
Dr. Manjari,
Has she joined? No.
She's going to join
Yeah,
very
good.
soon.
Yeah, I've joined. I'm in an area of low bandwidth, so I'll just be speaking.
Yes.
Thank
Good
you,
morning to
sir.
all. Yeah, yeah.
Good morning. Good morning.
Good morning.
Dr.
Good morning.
Manjari.
Dr. Manjari, I'm very lucky to get you today.
Uh, let's hope it results in good discussions here.
No?
तिवारी जी,
Yes, sir.
Dr. A.K. Singh,
Is he going to join? We are waiting for him, sir. Sir, he will join later on. Should we start right now?
and Sefali ji.
She's also going to join. She told me you may start. We will join very soon.
तो आप चाहें तो शुरू कर दीजिए।
Good morning. I'm Amresh Tiwari. I'm editor publisher of Double Helical magazine. This is a monthly health magazine being circulated for Delhi NCR region, Ghaziabad. Today we have the webinar and the topic is dementia. As you know that dementia is a senior elderly people disease and also for rarely for the child. So we have also for the child topics. We have the very eminent Dr. like Sefali. She is a very eminent and head of the child division, All India Institute of Medical Sciences. She is going to join. Now,
Good morning, Amrishi. I am there.
yeah. Thank you. Now we have the Dr. A.K. Agrawal. Is a Bhisham Pitama, you may say Bhisham Pitama of medical fraternity, and he is also medical advisor, clinical research and innovation, Apollo Group Hospital, and ex-dean of Maulana Azad Medical College. We have the doctor for the discussion today, very eminent personality like Dr. A.K. Singh. He is a former chairman and advisor, Max Institute of Neurosciences, Dehradun, and Dr. Binay Agrawal. He is a director of neurology, Medanta Hospital, Gurgaon, and Dr. very eminent Dr. Sanjay Saxena, director of neurology, Max his Hospital, Vaishali, and Dr. Manjari Tripathi. She is the head of the Department of Neurology, AIMS, New Delhi. Now I hand over Dr.
Tiwari ji, I am Vinay Goyal and I am chairman neurology at Medanta.
Yeah, sure. Dr. Binay Agrawal and chairman Medanta Group of Hospital, Medicity, Gurgaon. Now, sir, I hand over to Dr. Agrawal to start the today webinar. Thank you, sir. As a moderator.
Thank you very much, Tiwari ji. Thank you for giving me opportunity to moderate this particular webinar on dementia, and especially when my experts who are discussing the topic of dementia are some of the best ones available in our country. I will be introducing them individually when I talk to them. But what I understand, I'm not the subject expert of dementia. My subject is ENT. Maybe later on I'll try to correlate ENT to dementia in some other way. So, what I understand, dementia has become a big public health problem. And the numbers are increasing within India, globally. There are different figures which are coming, and numbers are increasing. So, my first question will go to my friend, Professor Vinay Goyal, who was in AIMS, New Delhi, and later on he joined as Director Neurology of Vedanta Hospital, Gurgaon. Vinay, thank you for joining.
Good morning, sir. Welcome, sir.
Can you give us a start with overall picture of dementia in India, globally, and what I understand, the overall incidence is increasing. What do you think the cause that it is increasing?
Sir, first of all, when I was a medical student in 1984, the expected life of India was 52 years. And today it is 72 years. From this basic statistics, we know that the age of the population has aged, increased expected age. And as we know, at about age of 85, 1 to 5% of population may have dementia. So the number of elderly population in countries increasing massively. And there's the data which says that by 2030, India will have largest number of geriatric population in the world because we are the largest population right now. But the geriatric population in the world will be largest. So we can understand the magnitude of the issue that India will have largest number of geriatric people as well as people with dementia or cognitive decline. So this is the severity of the illness that how this country is going to have a burden of people with dementia of different kind.
Vinay, thank you. Now, can I go to Dr. Manjari? Manjari, can you hear us?
Yes, I can hear you.
Thank you. Thank you. I know you, perhaps there is a difficulty in switching on the ground. Dr. Manjari is our HOD of neurology in AIMS, New Delhi, very eminent neurologist. Uh, Dr. Manjari, there are different forms of dementia, different varieties of dementia. Will you like to share with us which are the common varieties of dementias and which are a big clinical challenge for you?
Yes. So, we do
And before
identify.
that, can you define dementia?
Yeah. So, when I did my DM, we had the term dementia, but now we have the term major neurocognitive decline. This is supposed to be less stigmatizing than the word dementia. And this is a term we use now. And so the clinics these patients get seen in are the cognitive disorders clinics. Now, cognitive disorders are disorders which affect, several domains. And these domains, affliction causes them to be dependent on others. So basically, a person with major neurocognitive decline could have memory, could have reading, could have writing, could have calculation, could have comprehension, could have visuospatial, finding ways about, could have, judgment, insight, as well as behavior issues and social cognition. So there are many more domains, and if these are affected, and it is significant for the person to become dependent on someone for their activities of daily living. Then we
Ma'am,
say the
your video is
person.
not on.
Then we, sir, I'm in an area. I'm actually in a
It's
village area, so
okay.
I'm in an
Tiwariji,
area of, yeah. I'm in a little
uh,
area of low bandwidth.
Tiwariji,
So
Professor Manjari will speak and
yeah,
we may not be able
I'm
to hear
actually in
you.
my village in UP. So that is where we call the person as having major neurocognitive decline. And there are several causes. The commonest cause is, of course, which comes in very slowly and creeps on to a person, which is Alzheimer's dementia. It is the most classical form of dementia. Um, then we have what is known as vascular dementia, and I do believe that this is more common than Alzheimer's, at least in our country, where due to uncontrolled vascular risk factors like hypertension, diabetes, smoking, obesity, there are these different forms of cognitive decline which can occur due to different kind of small vessel blockages or large vessel blockages, which are multiple, or strategic locations in the brain, the vessels get blocked, which is strategic infarct dementia, or it could be due to changes in the brain which occur due to untreated hypertension, which causes subcortical leukoencephalopathy. So these are various forms of vascular dementia. And then, of course, we do have the amyloid angiopathy, which occurs with old age, where there's small bleeds or large bleeds, which can result in dementia. Then we move to the next category, which is very common and under recognized, which is there are symptoms like Parkinson's disease, but they are accompanied by a lot of hallucinations. And this is what we typically call the diffuse Lewy body disease. It has characteristic hallucinations, and probably this is the next commonest kind of dementia. Apart from that, we have other extrapyramidal disorders, particularly Parkinson's, which can be associated with cognitive decline. We can have a form of dementia which affects the front part of the brain, which is the frontotemporal dementias, where again there can be different manifestations, one of which is a disinhibited behavior. Then we move on to many more causes, some of which are reversible, like normal pressure hydrocephalus, where there is, increased volume of the CSF spaces, which need to be drained. Um, Nutritional dementias are not uncommon in our country. Hypothyroidism with dementia is not uncommon. And then now we're finding a new spectrum, which is known as the autoimmune paraneoplastic spectrum, which generally present with a rapidly progressive dementia. So we see a lot of autoimmune disorders, particularly the spectrum of Iglon and NMDA and Casper, which can present with cognitive decline. And they usually have a very fluctuating course and rapid progression. The paraneoplastic disorders which cause cognitive decline are also on the rise because of the increase in malignancies. So we do see patients coming in with, again, very short history with cognitive decline. They do have other features also like cerebellar or peripheral nerve involvement. Or then you have the dementias which could affect younger people, particularly vasculitis, vasculitic syndromes, but they usually have stroke-like episodes, headache, etc. And we also have, cognitive decline in the young, which could be due to Wilson's disease or be due to Kuff's disease. So there are several such causes, and there are metabolic causes, endocrinal causes. So actually, when we get a patient, we have to uh, take the history, and typically history taking takes a lot of time in a person with cognitive decline because you have to
So,
take the, whole day
as
history.
regard the diagnosis is concerned, the importance of history is one of the very important step, besides many more investigation which will be indicated. But Dr. Manjari, you did mention about the younger age group getting involved in the dementia. Can I go to Dr. Sefali Gulati? Dr. Sefali Gulati is our chief of Child Neuro Division in All India Institute of Medical Sciences. Welcome, Dr. Sefali Gulati. And you being
Thank you.
interested in the pediatric age group, and your domain is very well known all over. What is your observation as regard the numbers of youngsters getting involved into this condition, and which are the commonest condition you feel? Because this is very challenging. So far, we were talking about old age, and we were talking about 60 plus, 70 plus, perhaps we may say ये तो चलता है, तो old age के साथ चल रहा है. लेकिन यंगर एज ग्रुप में ऐसा होता है तो पेरेंट्स तो बहुत ही परेशान हो जाते हैं. इट्स ए बिगर चैलेंज.
Sir, yeah, childhood dementia is recently been started using as a term. Usme there is a collective impact and urgent need for awareness. Actually, most of this is a group of devastating conditions that cause progressive decline in adolescents. We were talking about the geriatric and the adults, but here it is that it is going to be starting in childhood and adolescent, and most of the pediatric neurologists have been using terms like neuroregressive and neurodegenerative diseases for the same. But they were having different temporal progression and different etiology. So now these conditions are increasingly being putting under the term childhood dementia and reflecting their clinical phenotype, and which is drawing on a parallel of the adult onset progressive cognitive decline. So this terminology shift has come recently for increasing the public awareness, for the same. And recently, in one of the journals, they had published that 145 genetic conditions could lead to this. In another 220 conditions have been said to be associated with this. With commonly, like we see Sanfilippo's, Niemann-Pick's, neuronal ceroid lipofuscinosis, mitochondrial disease, adrenoleukodystrophy, and generally the prevalence is around 1 in 2,900 births. But the childhood dementia leads to death before adulthood, and 70% of the individuals with a median life expectancy of just 9 years. But on the other hand, many neurological conditions can ultimately be have been shown to be a risk factor, having shown to be a association with more like early onset Alzheimer disease and related dementias, and certain chronic childhood diseases like even migraine, epilepsy, and certain psychiatric conditions have been shown to be related. So there are two different aspects to what we are dealing in pediatrics for dementia, sir.
Thank you. Thank you, Dr. Shefali. Strongly feel that this particular change of scenario is very, very alarming. And the entire medical fraternity has to be very, very careful. What we can do, we'll talk to you later on. Now, Dr. Sanjay Saxena, who is Director Neurology in our Max Vaishali, a very eminent
Yes, sir.
neurology. Dr. Sanjay, can you
Yes, sir.
hear me?
Good morning. Yeah, good morning, sir. Yes.
So, Dr. Manjari talked about the different variety of dementias. What had been your experience in your practice as regard the different common varieties, and where you have felt that, well, this is the major bulk we have to concentrate?
So,
Because it is a public
yeah,
health problem.
absolutely. So I personally, we all of us see many people coming to us with memory impairment, and this is a myth that memory impairment is dementia. So most of these people who come to us, they have some issues related to their lifestyle, their stress factors, and they are pseudo dementia. They don't have dementia, but younger people, most of them, they do have memory issues, behavioral issues, which cannot be defined as dementia. As Dr. Manjari and Dr. Vinay has rightly pointed out, there is a defined criteria to diagnose what is dementia. So these is the largest bulk which we see in the younger generation, less than say 30, 40s or 50s, who have a lot of stress related issues, and obviously they can't retain many things. They cannot carry on with their efficiency which they were having 10 years back, and they report to us with impairment of their functional aspect, their memory, their behavior, sleep, etc. And all we know, this is possibly a pseudo dementia, and it needs to be addressed in a different way. Now, when it comes to the major chunk of dementia patients, these are mostly in their 50s or 60s nowadays, slightly early age of onset. And we talk about the commonest type of dementia, that is the Alzheimer's disease, which is about 60 to 70% of the people. It used to be about age of onset were considered to be around 60 years, but now, as you know, in India, कहते हैं ना सठिया गया. So that actually meant this is the age of onset of dementia, and सठिया जाना is now 50 जाना, यानी 50s में भी start होने लगी है, and they are very unfortunate people. So, as Dr. Shefali was talking about neurodevelopmental problem with the child and pediatric age group, this is a neurodegenerative disorder where the brain has already evolved to a normal extent, and after that, it starts getting atrophic. The term used was cerebral atrophy for this topic, which is possibly a more of a coined by a neuroimaging of the brain. Atrophy would be just a mild atrophy related to senile development or senile growth. But in certain situations, cerebral atrophy may be related to dementia and other neurological disorders. Even epilepsy, there would be an atrophy or a particular part of the brain, hippocampus, that would give rise to epilepsy. So cerebral atrophy is not synonymous with dementia, and it's not a term to be we can use from the clinical context. So dementia is a huge burden in our society. It is increasing day by day. We see more and more patients who come to our dementia clinic, and of course, they have various subtypes of dementia. Vascular dementia is also coming up in a bigger way, because vascular dementia, apart from Alzheimer's, probably the second commonest type of dementia, which is related again to those risk factors which lead to cardiac involvement, brain stroke, and other renal and other involvement, that vascular involvement and ischemia. So these are the people who are now on the more increasing in their in their incidence, and we have to control and guide them apart from diagnosing a dementia to modify the risk factors. So it's a huge burden, and most of the patients they have. Apart from that, we do not have any cure for dementia even today. And what we have in
Right.
all.
Sanjay, I'll come to the cure part later
Right,
on.
right, right.
And now I go to my senior colleague, Professor Anil Kumar Singh, who had been the head of neurosurgery in GB Pant with me, and later on he decided to join corporate sector, and now he is the uh, director of neurosciences in Max Dehradun. Sir, welcome to you.
Morning. Good morning.
Good morning, sir.
Sir, can you hear me,
Yes,
Dr.
I
Singh?
can. Can you hear me?
Oh,
Yes,
yes,
sir.
we can. So, Dr. Singh, as a neurosurgeon, but as an important part of neurosciences, in a long journey of neurosciences, what had been your experience of dementia and what had been your contribution as regard the surgical part is concerned?
Okay. A brief introduction has already been given by both Dr. Goyal and Dr. Tripathi, and Dr. Saxena has added on to it. Basically, I would come in from the point of view of a non-neurological expert. Let me put it this way. So therefore, what we were taught and what still remains relevant clinically would be those kinds of dementias for which we do have something to offer, and those that we can only hope to manage. The first variety falls into the category that we call as broadly call as organic, the way we are able to find some or the other lesion. There are two varieties. One, what Dr. Tripathi elaborated on, which is vascular. So if you can prevent in time the vascular damage, then you can hope to reduce or even reverse. The point where neurosurgeons come in is when there is a mass lesion of some variety, which is leading to the reduced functioning of the normal brain, which then presents itself as a loss of mind, which is what dementia is basically. So उसमें the category that dominant categories are two. One is what we call as increased fluid in the brain, which is hydrocephalus. Usually in elderly people, that will be called as a normal pressure hydrocephalus. The pressure is not high, but the fluid content is high. So therefore, the normal functioning of brain suffers. Or there might be tumors. Tumor is a very generic term. It could be infective, neoplastic, or whatever. So something that is occupying the brain, something that is not supposed to be there and is occupying the cranial cavity, which is causing pressure on the normal tissues. Now this presents again as a reduced brain functioning, which would then be perceived by everybody as being अभी तो दिमाग कम हो गया, याददाश्त नहीं रह रही वगैरह वगैरह, abnormal behavior हो रहा है. So those are depending upon what area the brain is involved. So therefore, those are two things that are amenable to surgical intervention. And some degree of improvement does usually occur following them. The improvement depending upon the illness, can be variable, can be lifelong, can be nearly complete, or can be minimal.
Thank you, sir. Thank you, Dr. Singh.
Hmm.
Dr. Vinay, now the patient has come to you. Patient is educated. He is suspecting that I am losing memory, there is something wrong, and some other symptoms which are part of dementia. Uh, as Dr. Manjari said, history taking is of utmost importance. But which are the commonest investigations which you feel should be recommended? Minimum possible.
Yes, sir. Sir, first, as you mentioned at the beginning of this, that first we need to dimension, and Dr. Sanjay was emphasizing very clearly. First, we need to know, is it really a dementia? Because now the youngsters in their 30s and 40s are they are coming कि मेरे को याद नहीं रहता, मुझे याद नहीं रहता. So these are the youngsters who come to you presenting as dementia, but when we do cognitive assessment, so like bedside is doing minimal examination, MMSE, if it is less than 24, we consider for further investigation. But most of these are stress related because of work, because of family, because of society, because of finances. So first we define whether they have really dementia or they don't have a dementia. That is one thing. Once you know this is a dementia, then we do some battery of investigation, which are bedside scales to know what type of dementia it is. And from the history, patient had recurrent stroke or poorly nourished or had family history of dementia. Then from that, you know that what is the different type of dementia they have. For basic investigation, one thing I have learned is first to do a one basic imaging. Basic imaging could be NCCT head, but MRI brain will be preferred because you could see a lot of white matter changes. This reminds me of one simple case. When I was a resident, I discussed this case as a around 49-year-old lady. We discussed this on the round, like Alzheimer disease. The presentation was like this. In the evening, when the first NCCT had come, it had a large meningioma, frontal meningioma. And that taught me a lesson of life that a treatable, like AK Singh sir was telling that this is a treatable disease. If you have a tumor, you remove it, your symptom will go back. So sometimes the clinical presentation may be so misleading. And we discussed this case with Dr. Prasad next day morning without telling him the imaging. Again, our clinical diagnosis was same. So the clinical diagnosis sometimes could be misleading, and doing one imaging is must to rule out treatable disorder like tumor, hydrocephalus, and sometimes infection or subdural hematoma, which are common in elderly people. Second thing would be to do some blood tests, which will be hemogram, basic LFT, KFT. B12 level is one. These are among the basic ones. When the basics are common, then you do want to do more advanced. Then you want to do EEG to look for some of the different type of dementia. Now we have a PET scan to look into different metabolism of the different lobes of the brain, and from that basis we can define whether it is an Alzheimer type or FTD type or Lewy body type. There are also some advanced tests which are currently not available. Mainly, they are investigational that you could do a CSF and look at the amyloid level and other molecules in the CSF. But these are actually not required for the basic workup of day-to-day working. So this way, I will call them more of a research tool. So for basic workup, doing one imaging and routine blood test is usually good enough. Sir, your voice is not coming.
Thank you, Vinay.
Yes, sir.
Dr. Manjari? Dr. Manjari,
Yes, please.
can you hear me?
Carry on.
Right. So, if I come to you and I am ready to get investigated, provided all the investigations you are undertaking may lead to a definitive diagnosis which will help into my treatment to be more focused, right?
Yeah.
So it's like Vinay said that we would like to have step one investigation, then number two and number three, right? And what had been your experience by having a battery of test investigations? Are you do you think we are able to pinpoint a condition where the outcome of the patient is worried about the outcome and may improve?
So actually, the the most important thing is to take a detailed history and do a neurocognitive, brief test. And nowadays, we mostly do the MOCA, which is Montreal Cognitive Assessment, and this has been normalized for the Hindi speaking as well as multiple other language speaking population in our country. Uh, we have to rule out pseudodementia. Uh, and the commonest cause of pseudodementia in the older people is depression. So we have to do a brief Beck depression inventory. Um, Once we've ruled out depression, one must do all the routine tests. And the routine tests would involve doing the renal functions, the liver functions. Um, you will have to do thyroids. In elderly who have shorter duration, we do TPO antibodies also. Um, and we also then advise for the B12 levels, homocysteine levels. If it's very rapidly progressive, we ask for the paraneoplastic profile as well as the autoimmune profile. Um, then, of course, most important is a neuroimaging, and the best neuroimaging tool is the MRI. And there is a dementia protocol for MRI, and that protocol includes arterial spin labeling, which is otherwise the poor man's pet, and also includes the SWI sequences to look for microbleeds. Because if you don't do these sequences, you will miss the microbleeds and you may not pick up the diagnosis of amyloid angiopathy. So, a dementia protocol MRI is the best if the patient is cooperative. Um, the MRI usually takes typically half an hour because it has all these other sequences to be done. And then we call the patient with all these investigations again and look at it. And if there is a very short history with myoclonic jerks, or if the imaging is suggestive, even if there are no myoclonic jerks, the imaging shows certain features which are for prion diseases, then we also do an EEG. We also do an EEG for the autoimmune dementias. So EEG is also a part of the investigation. And in younger people, of course, you would have to do the nerve conductions if it's metachromatic or VLCFA, or the uh, screening for metabolic disorders, including doing a slit lamp examination or
I mean,
urine
you would
for.
like to undertake all the investigation to rule out each and
Absolutely,
every
yeah, yeah,
cause and
yeah,
treat the cause accordingly if required.
absolutely, absolutely.
Hmm? Dr. Sefali, Dr. Sefali,
Yes, sir.
I'm a bit worried. I'm really worried, especially in your domain, where our young children, especially post-COVID, the scenario of children getting glued to the big screen or a small screen, isolation, tendency of playing with the friends outside is decreasing, perhaps compulsory isolation. And I understand that it has changed the scenario among children a lot. And of course, today we are not talking about any other child development problem and all. That is a different thing. But do you think it is also trying to affect somewhere in a younger dementia problem also?
Thanks for the question, sir.
Isolation.
And I would like to answer, and I also want to answer with reference to what Dr. Sanjay said. So I wanted to clarify that when I am saying for childhood dementia, I am not talking about neurodevelopmental disorders. I am mentioning the neuroregression and the neurodegenerative disorders. Neurodevelopmental disorders is not the question today, but the screen time, what you are saying, has been shown to be associated with more problems in the neurodevelopmental domain. So they have not shown to cause the regression part. Yes, because some children are having more autism, some children are having more other neurobehavioral problems, which are not the point of today's discussion, but it has till date, sir, it's not shown to be, related to this dementia, where I will again emphasize it's neurodegeneration and neuroregression, which we are talking about. And because two-thirds of the conditions can be because of inborn errors of metabolism. So those countries who have newborn screening, they get identified early, but we don't have newborn screening as of now. So we have to pick them up early and give specific, the treatments for them, because you have for neuro metabolic disorders, many of them have specific treatments as well. And also, sir, this dementia has certain infectious and nutritional deficiencies which can contribute to it. Yes, because you are talking from that point of view, from the LMICs. And currently, sir, there is a childhood global dementia consensus activity going on, and we are having its meetings next week as well, in which a group of global researchers from pediatric neurology are trying to come around, because we have to pick these children early and try to give whatever treatment is possible, and provide also multidisciplinary care for pain, behavioral, psychological, sleep issues, and mobility issues, seizure, hearing, vision, feeding, all these problems. So they have been totally neglected, so that those things have to come up, and more research is also being advocated, so that we have some biomarkers and certain points for precision medicine in this. So this childhood dementia term has now recently come up, and is very important to understand. And because these are in parallel to the adult dementia, but they are going to mostly have a 70% of them are not going to adulthood. So in that, but sir, your this screen time maybe associated, I haven't looked into it, is the other category which we were talking about, that certain chronic neurological conditions like migraine, epilepsy, and various other neuropsychiatric manifestations have been shown to be associated with the early onset Alzheimer and related dementia. So I think I will have to do a search on it to see whether screen, I haven't come across, but whether screen time may ultimately be. So what you were saying is there's a possibility there for the early onset in the adulthood one. It may be there, sir. Your point of concern is pretty valid. But this has not been studied, and I'll have to look into it.
Thank you. I
So
think
because that's very important, preventable. But come to one thing is that, but one thing is there's a screen time has to be limited for all across all ages.
correct.
There is there's addiction to screen time across all ages, so one has to do it.
So this is not only dementia, the screen time has to be restricted. There is no doubt about that. There is no doubt about that. Uh, Dr. Sanjay, there was one question in my mind which I am asking you, but my any other colleague may also answer. Like we take the example of Japan, where a good number of population is 100 plus, and there are super centenary 110 plus and all. What do you think is the uh, in that category of group? Do you think dementia is more, or they are uh, perhaps not suffering with dementia that much?
So it's a very valid question. I think, sir, there is a paradox. Japan is known to have lesser incidence of dementia prevalence and incidence and of dementia as compared to many other developed countries, in spite of having elderly people who live up to 90s or 80s with a large chunk of the people. So there are various factors, though we have not been able to pinpoint and find the exact etiology for neurodegenerative disorders or immunology. The factors which might be responsible is their lifestyle. That is one. Their maybe genetic constitution. Secondly, and maybe something which we need to find out in the other population why they are getting dementia at a very fast rate. We are adding at least 10 to 12 million people going into the category of dementia every year the worldwide. So this is a topic of I think contemplation. May other speakers may also contribute to this question.
I, any comment from Manjari? Dr. Manjari, any comment from your side?
Yes, definitely. Dr. Vinay said in the beginning that the aging population is going to increase, and many more clinicians, neurologists, geriatricians, pediatricians all need to gear up for diagnosing these cases, for managing these cases. It's not just the patient, but also the caregiver, which needs attention and who needs attention, because there is significant caregiver burden and caregiver stress also, which builds up. Looking after elderly with cognitive issues or even younger people with cognitive issues. So there needs to be a large scale, awareness as well as, competency in managing these disorders. Of late, for Alzheimer's, we have biomarkers which are being done in the CSF and plasma. And this is because we have moved from a clinical diagnosis to a biomarker based diagnosis. And there are on the annual therapies which are entering the Indian market by June next year, which are monoclonal antibodies for early Alzheimer's and mild cognitive impairment due to Alzheimer's based on the biomarker based diagnosis. So we also need to be competent enough to be knowing about these biomarkers and their interpretation, as well as then the management with the antibodies, which needs to build up, as they are probably the only way that we can reduce amyloid beta burden in the brain as of now.
Okay, Dr. Manjari, I think I agree that the recent trend of having various biomarkers, and I'm also part of some research committees in the town, and I find that so many biomarkers are under trial also. Of course, beside the genetic studies, so these two things are very important as regard biomarkers and genetic studies. And perhaps we have to find a solution where the monoclonal antibodies mm, may prove to be useful. Do you think, Dr. Manjari, it is already there in market or under trial where we are trying to find out some medicine, what you call some medical treatment?
So the biomarkers are already there. They are available by different diagnostics. There's
Yes.
Agape Diagnostics, there's Roche Diagnostics. They're available in a majority of the private labs now. At
Mm.
AIMS, we are doing CSF and plasma biomarkers. We are doing the amyloid beta, as well as A beta 42, as well as p tau 217. So these have been standardized by our, cognitive disorders neurologists, which is myself and Dr. Anu Gupta. And we also have them being done in our research biochemistry lab. But they are available in commercial kits now. The only problem with the commercial kits is that I do not know if they have standardized and validated in the Indian population of that region, vis-a-vis elderly, normal elderly, because you need to validate and standardize the norms for that particular population, which will vary according to the ethnicity.
Okay.
So that
That
is the
means the
only thing.
parallel
Yeah.
research has to go on regarding the validation. Commercially, anything may come up, but ultimately, it's a question of time that it gets proved that it is really useful or not. Dr. Sefali,
Yes, sir.
Dr. Sefali, yes. Now the question is, uh, in younger age, I'm more worried about my younger age. The way you said and everybody said, the numbers are increasing. What solution you are offering?
Sir, I think the solution lies in basically first is we have to, in the first category of the childhood dementia, we need to identify them early and start appropriate treatment because they are getting missed, and two-thirds of them are inborn errors of metabolism. And even those who are degenerative, like those NCL and all, and adrenoleukodystrophy, they're coming to us late. So we need to have research on to pick up the biomarkers, to pick them up early. For example, adrenoleukodystrophy, we are doing hematopoietic stem cell transplantation. But if they are advanced, you cannot revert it back. But if it is pre-symptomatic or early, then we can have their good results. We have been doing them regularly. So, but many of the cases when we do our multidisciplinary meeting, we have to decline them because they are picked up late. So we have to pick up early, and many definitive treatments are coming up, and more research also to do the biomarker bit. And the that second group of younger kids who are not demented but going to lead to the adult population to have dementia, I think that area has to be, more studies have to take place, because that will be prevention of dementia in the long run. And as the longevity is there, although there's been one very good study was there recently in which they had done, but we need to more. This was a study. This was from China, in which they found lifelong association with childhood multimorbidity and early and late onset dementia. Multi-cohort study they had done, and they found association with minor things, migraine and epilepsy and
Dr. Shefali? Yes.
to be that, and maybe we have to collaborate with pediatric and adult neurologists together to follow up these children and understand. Yeah.
All right.
And screen time, yes, screen time को भी देखना पड़ेगा.
It's very important. Dr. Sanjay? Dr. Sanjay? Sanjay, can you hear me? Tiwari ji, can you hear me?
Yeah, yes, sir. Yes, sir.
संजय को मेरी आवाज पहुंच रही है?
Yeah, yeah.
Dr. Sanjay, I don't see him in the list now.
Dr. Sanjay?
सर का डिस्कनेक्ट हो गया डॉक्टर संजय का लग रहा है.
विनय,
हाँ सर.
now my passion is deafness prevention
Yes,
as
sir.
ENT, and whenever I go to WHO headquarters in Geneva,
Dr. Sanjay
I
is on,
find
sir.
lot of literature.
Yeah, Sanjay is here.
Vinay,
हाँ सर.
I find lot of literature and relationship of hearing loss, hearing disconnect to dementia,
Yes, sir.
right? So the sensory disconnect, whether it is hearing or visual, are very much literature-wise linked to onset and progress of dementia.
Yes, sir.
And in my day-to-day, I don't practice, but whatever you may say, experience is that if I find and if I am able to give some improvement in a patient or friend of mine where the hearing loss was very severe, perhaps his tendency of dementia or depression, especially, uh, that improves. So, what is your comment?
Sir, I'll start with an anecdote. When I was in PJ Chandigarh for some time, junior agent worked up a case and brought a patient. He said he is severely demented. He can't understand anything and he is not answering anything. Then we realized he's stone deaf. So the youngster did not realize he is not able to hear himself. So he didn't answer the questions and he said he's severely demented. And that taught a lesson for me. For all people who come to me with cognitive decline, I also look into it whether their hearing is okay. And sometimes I tell them to wear their hearing aid and come so that I can talk to them.
Correct.
And I personally believe very strongly that this hearing loss in elderly is a very important preventable cause of developing dementia. When you don't hear, you don't perceive, so your inputs are going down. People don't talk to you. You don't want to talk to the people because you can't hear them. So this communication,
It's bilateral.
yes, sir, bilateral. The communication goes down, and they remain isolated in the society and in the family, even in the house. And that is the important reason for cognitive decline. Because as I say कि जितना आप बात करेंगे उतना आप अच्छा रहेंगे. मैं हमेशा ये बोलता
इसका
हूँ.
मतलब जितना एक्टिव रहना है एक्टिव रहो,
नहीं, एक्टिव के साथ बात भी करना है सर.
बात भी करना है।
आजकल मेरा एक जो एल्डरली लोग होते हैं उनको बोलते हैं, जब आप मॉर्निंग में वॉक करने जाते हैं तो जहाँ वॉक करते हैं गार्डन में, वहाँ बैठ कम से कम 1 घंटा बैठिए और लोगों से बात करिए, क्योंकि घर में आजकल न्यूक्लियर फैमिली होगी, बात करने वाला है ही नहीं कोई. तो वहाँ बैठ के बात करिए. और दो चीज़ बताता हूँ. एक तो बात करिए, तो कुछ लोग बोलते हैं क्या बात करें. मैंने कहा कुछ भी करो. आस पड़ोस के बारे में करो, एनवायरनमेंट के बारे में करो, पॉल्यूशन के बारे में करो,
जिसके
पॉलिटिक्स
बारे
के
में
बारे में करो, जोक्स के बारे में करो. और मैं तो ये भी बोलता हूँ, कुछ भी नहीं समझ में आ रहा तो उल्टी सीधी फेंको, मतलब झूठ बोल दो, कोई बात नहीं,
हम लोग
बट
अपने ग्रुप में कहते हैं कार्ड्स खेलो।
हाँ, कार्ड सर. कार्ड तो मैंने एक बार नेशनल टेलीविजन पे कहा था कि कार्ड 10 रुपए के, 20 रुपए का कार्ड आता है, उसे 8 लोग खेल सकते हैं. इससे सस्ता तो इंस्ट्रूमेंट नहीं है कॉग्निटिव. और कार्ड खेलने के लिए आपको दिमाग लगाना पड़ेगा कि सामने वाले के कार्ड्स क्या होंगे, उसने क्या चला है, पत्ते याद रखने पड़ेंगे. दूसरी एक बात और मैं बोलता हूँ, जब आप मॉर्निंग में वॉक करने जाते हैं, बात करते हैं, तो एक चाय वाले को हायर करिए. वो डेली आपको सुबह चाय देगा, वो 10 रुपए सबसे लेगा या एक जना एक बार दे दे. उससे क्या होगा, मॉर्निंग में अगर जो कोई नहीं जा रहा है तो उसको उस चाय की याद आएगी कि यार वहाँ चाय मिलेगी, चलो चाय पीने चलते हैं. आदमी जाएगा, बैठेगा, बात करेगा, और चाय पीएंगे तो आधा पौन घंटे वहाँ बैठेंगे भी. सो इट विल बी काइंड ऑफ अ सोशल इंटरेक्शन. और इस एज में सोशल इंटरेक्शन इज, आई थिंक, इज वेरी इंपॉर्टेंट. न्यूक्लियर फैमिली में इन बुजुर्गों से बात करने वाला कोई नहीं है. सुबह से शाम तक बच्चे काम पे चले जाते हैं. रात को जब थके हारे आते हैं तो आधा घंटे माँ बाप से बात करते हैं, फिर अपने काम में लग जाते हैं. तो ये इनके साथ बात कौन करे, और वो भी किससे बात करें. तीसरी बात मैं उनको बोलता हूँ कि आप जो है ना, सारे रिश्तेदारों को नंबर नंबर लगा के फ़ोन करो. हो सकता है वीडियो कॉल करो, जिससे उनकी शक्ल याद रहे. नहीं तो क्या होता है, 2 साल बाद किसी से बात करते हैं, उनको शक्ल याद नहीं रहती कि ये कौन है. तो अगर आप वीडियो कॉल पे बात करेंगे या फ़ोन से बात करेंगे तो आपका कम्युनिकेशन बना रहेगा. फैमिली की न्यूज़ मिलती रहेगी तो आपके लिए बात करने का टॉपिक बन जाएगा. तो मेरा ये छोटी थोड़ा सा बियॉन्ड द मेडिकल
बिल्कुल
साइंस.
ठीक कह रहे हो। आई थिंक you are absolutely correct, and we have to. All these things are very important, very
यस.
important. And I think time is now getting finished. My last question, Dr. A.K. Singh, sir. Dr. Singh,
Yeah.
सर, ये जो डिमेंशिया का चैलेंज है, इसको डील करने के लिए देर आर एक्सपर्ट इन फ्रंट ऑफ अस, दे आर डूइंग एडवांस रिसर्च ऑल ओवर द वर्ल्ड, थिंग्स आर कमिंग अप, लेकिन हमारा अपना जो एक इंटीग्रेटेड सिस्टम था और है इंडिया में, डू यू थिंक उसका भी एक कोई इम्पोर्टेंट रोल है उसको?
Actually, I want to make three comments. I
जी
really liked what Vinay was saying a short while ago in terms of management. The three comments belong to three categories. The first one is the nomenclature. As Manjari pointed out right in the beginning, that the definition of the nomenclature has been changed from dementia to neurocognitive disorders. Now, dementia classically, every word has an etymology from where it arose. Basically, dementia is a term which has a Latin origin, which means basically losing mind. So you have to have a mind which you lose. So congenital or developmental problem does not really fall into the same category. It is a neurocognitive disorder, but possibly it is inappropriate to call it a dementia. That is one. एंड जो संजय ने कहा था कि जो है हम लोग इसको कॉमन पार्लेंस में बोलते हैं, सठिया गए हैं, दिमाग फिर गया है, वह टहल गया है. And that is a very important thing, that is what we are here for. We are clinicians, right? There are two aspects to medicine. One is clinical, the other is the research medicine. So we're talking from the clinical point of view. Then we come to the stages. There is a pre-cognitive disorder, pre-dementia stage, which is when they can still be, if people are caught at that stage, screened at that point of time, which is called as MCI, minimally cognitive impairment. So उस स्टेज में अगर पकड़ में आ जाते हैं लोग बाग, जो विनय बता रहे थे कि भाई नाम याद नहीं रहा, नंबर कहाँ रखा था, वो या सिंपल थिंग्स जिसमें हेयरिंग एटसेट्रा ऑल्सो मैटर, तो वो वाली स्टेज में पकड़ में आने में देयर इज अ पॉसिबिलिटी ऑफ लाइफस्टाइल मॉडिफिकेशन हेल्पिंग. ठीक है. So therefore, and then we have the stage 1, which is becoming, but is still not troublesome. Stage 2 is pretty troublesome, and stage 3 is unmanageable. It is what we call as a hospital-based or institution-based care. उसका हमारे यहाँ कोई इंतजाम नहीं है. Stage 2 and stage 3, we have practically no arrangement at all. And while you were talking about the pediatric age group and the elderly age group, and your this thing about the pediatric age group, the pediatric age group always has parents. हम लोग का सारा पैसा, ध्यान, लव जो लगता है वो बच्चों पे लगता है. So therefore there are caregivers. When you become a 70-year-old chap or a man or woman, now you've lived your life. And as somebody pointed out, our average age now is 72. So if you've crossed at 72, then you are now in the borrowed period of time. So you will have to go at some point of time or another. So why bother too much? Especially in a nuclear family with limited resources in terms of time and money. So what do we do with these people? And this is a very practical problem that everybody who has an access or is caring after patients in a neurocritical care unit faces. What do you do with these people? When they go home, the cost is so high that an average common middle class Indian cannot look after them.
Correct.
Now, joint family also makes it a problem. So that's a very, very major therapeutic or management issue, which cannot be sorted out by individual doctors. It cannot be sorted out by individual hospitals either. This is a social problem which only the governments can handle. So this is for the policymakers, and it is our job that we should make the policymakers aware of these problems. The individuals do not have that kind of attraction, so it is our job to magazines like Double Helical to create that traction. So those are the major issues that we encounter. MCI, we keep talking about it. We talk about it in our lectures here and there and everywhere. But at least I don't see many clinics performing that, focusing on that kind of a thing. From now, who should be looking after, whether it should be a psychiatrist or a psychologist or a neurologist? Typically, what happens in Indian practice scenario is that each person looks after by themselves. They don't interact by and large. By and large, they do not interact. Individual practitioners. So whoever comes to me, depending upon my area of interest, I take care. I do not say go to XYZ, go to Vinay Goyal or Saxena. करना उन्हें भी कुछ नहीं है. ठीक है ना, दवा तो कोई है नहीं, तो किस बात के लिए? जांच करा लो, ये दवा करते रहो, खाते रहो. It's more like giving palliatives. So basically, the management scenario currently is pretty bad. As Dr. Tripathi was pointing out, there are many biochemical markers becoming available. The question obviously would be, how would we be able to use them? We have monoclonal antibodies for trying to control. We have lifestyle changes that Dr. Shefali pointed out, and other such things. But we are not very clear as to how they would help, and there are no organized clinics looking after it. That's where my major concern is. And I say this because in my group, I have neurologists, neurosurgeons, psychiatrists, and psychologists. Last 20 years, my group has all these people in one group. And despite that, we've not been able to actually create a good Alzheimer or dementia clinic.
Right. Sir, I think time may
Sir,
not permit us.
sir, sir,
Yes.
10 seconds, एक second, sir. आपने वो digital का बोला. There is a term digital dementia, which I was not aware of, was coined way back in 2012 by a German psychiatrist and a neuroscientist. And there's a published study in 2023 from 4,62,000 participants, and they have shown that more than 4 years of screen time was associated with increased risk of vascular dementia, Alzheimer disease, and all-cause dementia in participants. Scary.
Causes part, I am not too sure, but the other part is right. Causes part is debatable.
Yeah, I don't know, sir. They're just associations, na? So associations
Association.
have,
Yes. Association,
it's
yes.
not causality, sir. It's just
Association, yes.
association. So I was just saying we have to look into it. It's a preventable, hai na, sir?
That's, I
Yes,
think
yes, yes.
these are the aspects which we had to look into it. I think there may be few questions, Tiwari ji, लेकिन उससे पहले कि मैं questions पे जाऊं, I would like to have a very one single comment from all of you. Dr. Vinay, one
Sir, sorry to
small
give you, sir.
comment, a message from your side.
Sorry to intervene. We have also with Dr. V.S. Mehta as our audience today.
Dr. Mehta?
Yes, good morning, Dr. Agarwal. Good
Dr.
morning.
Mehta, where are you?
I'm
Oh,
at home. I'm in having severe cold and cough. I didn't join that.
so nice to hear you. So nice to hear you. And God bless.
So
Yes,
I'm only saying that yes, prevention is important, and we should all focus on prevention of dementia, which are preventable. There are certain dementias which can be preventable, and we should focus on prevention definitely.
thank you. Thank you, Dr. Mehta. Ji, Vinay,
Yes, sir.
one single message from your side
Yes,
to
sir.
the society.
Yes, sir. Good morning, Mehta, sir.
Good morning. Good morning.
My message, and whenever I talk in people with elderly population, I always say use it or lose it. तो आप जितना दिमाग को यूज करेंगे जितना एक्टिव रहेंगे एंड आई थिंक अमॉन्ग अस मेहता सर इज द बेस्ट एग्जांपल ही हैज बीन वर्किंग स्टिल टुडे एंड वेरी एक्टिव मॉर्निंग सुबह 8 बजे से रात को 8 बजे तक काम करते हैं एंड ही इज इंटरेक्टिंग विद दिस पेशेंट सो मेरे पास सर पार्किंसन के पेशेंट बहुत आते हैं एंड दे वांट टू टेक वॉलंटरी रिटायरमेंट सो माय आई ऑलवेज टेल देम इफ यू टेक वॉलंटरी रिटायरमेंट आई विल नॉट सी यू एनी मोर बिकॉज इफ यू वांट टू रिटायर एंड सिट होम तो आपको पार्किंसन का इलाज कराने की जरूरत नहीं है तो कीप वर्किंग सम ऑफ देम हैव जॉइंड देयर बैक होम देयर बिजनेस देयर ऑफिस so they remain cognitively intact mobility may be affected but at least cognitive part is taken care when they're active in the society.
Correct, correct. Dr. Manjari, message from your
Uh,
side.
yes, so my message would be that, one has to develop cognitive resilience, um, as well as the community and the society and the family have to be geared to investing into brain health as it ages. And that investment doesn't start at the age of 60, it starts right from the day you're born. It depends on the nutrition, on education, on learning new things, even as we age, correcting vision, correcting hearing, not leading a sedentary lifestyle, eating the right foods. So there are several such things which go into developing cognitive resilience, and that should be taught to each one of us in school as we learn in college.
Thank you, Dr. Manjari. Dr. Shefali,
The scientific aspect हम बात कर चुके हैं. I think I just want to mention that we have to look at humanistic aspect of everything, and each life born has equal right to dignified life. Dignified has to be capped and bold.
correct.
We have to remember,
Well,
and it is not me phenomena. We may have a similar problem. So empathy and understanding humanity.
thank you. Thank you. Sanjay,
So I would say dementia is usually detected at a very advanced stage because people are ignorant about it. They don't accept it. So we have to spread the awareness from various platforms to make people aware that early detection, early intervention, and changing the lifestyle and some medical aspect can make a lot of difference to the quality of life of the individual and the caregivers.
Dr. Singh, sir, a small message from your side.
Yes, good morning. It took me
Good
some time to
morning.
recognize
AK,
you.
you are looking smart today.
Here we are. We'll talk later. Arun, about this, I completely agree with what VS has been doing and what Vinay said. Just want to add one thing that daily meditation, chanting also helps. and not everybody is an extrovert. Everybody may not follow what Vinay was saying, go out and have a cup of tea. Some people might prefer to go and meditate. You got sons of 98 years of age, bright and clear in the mind. So the mind must remain occupied. Whether you're occupied with things outside or you're occupied with things, अलग चीजें जो होती हैं. So remain occupied.
थैंक यू। अमरीश तिवारी जी, अब देखिए आपके पास कुछ क्वेश्चंस हैं तो आप
Yes,
इंडिविजुअली
sir.
पूछ लीजिए।
I have published. I
Sir,
have published.
can I add one point?
यस सर।
Sir, can I add one point? I also want to do Dr. Shefali ने भी कहा कि these elderly people, we know their cognition is going to go down gradually, and sometimes family is not able to cope up with them. So I tell them that currently he is like a 5-year-old child or 3-year-old child. जब वो 3 साल का बच्चा कुछ नहीं समझता है, हमको दोबारा रिपीट करना पड़ता है, दोबारा समझाना पड़ता है, तो हम तो उसको बड़ा मजे से बात करते हैं कि देखो एक बार समझाया नहीं समझा, 2 बार समझाया नहीं समझा, और हमको 10 बार समझाते हैं। लेकिन यही एल्डरली आदमी अगर जो एक बार में नहीं सुनता है या यही बात दोबारा पूछ लेता है तो फैमिली झुझुलाने लगती है, कई बार लोग उसके उनके साथ मिसबिहेव करने लगते हैं। तो मैं हमेशा एक ये भी मैसेज देता हूँ कि अपार्ट फ्रॉम देयर न्यूट्रिशन, हेल्थ एंड हाइजीन, एवरीथिंग, giving them love and care is very important. I see very often in OPD, I see the son and father are fighting because फादर को समझ में नहीं आया तो सन चिढ़ जाता है, कभी तो बताया डॉक्टर साहब ने, फिर दोबारा पूछ रहे हो। तो दिस कम्युनिकेशन बिटवीन द टू इज ग्रेजुअली विद थिनिंग ऑफ। सो आई ऑलवेज से कि अगर ये तुम्हारा 3 साल का बच्चा होता तो तुम्हें बड़ा मजा आता कि डॉक्टर साहब से दोबारा पूछा है इसने, और ये 90 साल के 80 साल के पिताजी हैं तो तुम्हें बुरा लग रहा है कि इन्होंने डॉक्टर साहब से दोबारा पूछा। ये मैसेज हम सारे फिजिशियंस को भी देना चाहिए कि व्हाट दे वो को जानबूझ करके तो नहीं कर रहे हैं, क्योंकि वो कई बार एक ही सवाल हर 1 घंटे में 5-5 मिनट पे पूछते हैं, तो फैमिली को गुस्सा आ
वो
जाता
एक
है।
चीज बताई गई है विनय,
यस सर।
कि बच्चा बूढ़ा एक समान।
यस सर, सेम
ठीक है ना।
सिचुएशन। और मैं बोलता
सो
हूँ ये बच्चा तो सुधर जाएगा, लेकिन ये बुजुर्ग जो है वो और डाउन जाएंगे, तो हमको उनको प्यार से ही रखना पड़ेगा।
जी तिवारी जी, अब आप क्वेश्चन पूछ लीजिए।
Sir, this question direct goes to Dr. Binay Agrawal Saab.
विनय
Sir,
गोयल
can
सर।
you take us this question from Bangalore, Navin Rao?
जी
He's asking, are there any new breakthroughs in diagnosing dementia at early stage?
देखिए ऐसा है सर, अभी डॉक्टर मंजरी ने बड़ा एलेबोरेट किया था कि बहुत सारी नई दवाइयाँ आ गई हैं जो कि अभी इंडिया में अप्रूव नहीं है, लेकिन दूसरे कंट्रीज में अवेलेबल हैं। उनका नाम मैं नहीं बताता हूँ, नहीं तो लोग गूगल करके उसको ढूंढने लगते हैं एंड दे स्टार्ट सर्चिंग। पर आपको ये समझना चाहिए ये दवाइयाँ कोई भी मैजिक नहीं है, उनकी कॉस्ट अभी बहुत एक्सूरेंटली हाई है। कुछ ऐसी दवाइयाँ हैं जिनकी कॉस्ट करीब 50 लाख भी जा रही है। तो मतलब ऐसी दवाई को चेज करने का कोई मतलब नहीं है। अभी इंडिया में वो इलीगली अवेलेबल भी नहीं है, किसी फार्मास्यूटिकल कंपनी, इंडियन गवर्नमेंट ने उसको अप्रूव भी नहीं किया है। बट दोज हु कैन अफोर्ड एन एक्सपेंसिव ट्रीटमेंट, दे कैन visit international clinics of dementia, and where they will find that these some of the 2-3 molecules which have been approved recently last 2 years, they will be able to procure from there. तो और बाकी जो हम दवाइयाँ हैं जो स्टैंडर्ड हैं, जो हम हमेशा रेगुलरली यूज़ करते हैं, जैसा कि अपने सिंह सर ने कहा कि वो कोई दवाइयाँ कोई जादू जैसी दवाइयाँ तो है नहीं, लेकिन कुछ लोगों में बिहेवियर इंप्रूव होता है, कुछ लोगों में वेलबींग इंप्रूव होता है। अगर तो उतना भी हमारा अचीव हो जाए तो वो अच्छी बात है। पर दवाइयों से ज़्यादा जो नॉन फार्माकोलॉजिकल मेथड्स हैं, जैसे कि हम अभी तक कितनी बार डिस्कस कर रहे हैं कि कम्युनिकेट कर रहे हैं, एक्सरसाइज कर रहे हैं, अच्छा खाएं, अच्छे विचार रखें, सिंह सर ने बताया मेडिटेशन करें, तो ये सारी चीज़ें भी मुझे लगता है इक्वली इंपॉर्टेंट है, जो डूएबल है। तो वो उस जो चीज़ों को ध्यान रखना पड़ेगा हमको। जी तिवारी जी।
Next question goes to Dr. Manjari Tripathi, please. Are you getting me, Dr. Manjari? Dr. Manjari, please. Hello. No issue. Dr. Sanjay Malhotra Sahab, can you tell us how effective are current treatment options in showing the sorry. Yeah, what lifestyle changes have proven to reduce the risk of developing dementia?
Sir, may actually I was can I answer? Hello?
Yeah, you may answer, please.
Okay. So lifestyle changes में जो risk and prevention जो strategies हैं, रिस्क को अवॉइड करना है और प्रिवेंशन स्ट्रैटेजीज अपनानी है। रिस्क देखिए, जो इरिवर्सिबल रिस्क फैक्टर्स हैं वो तो हम चेंज नहीं कर सकते हैं। उसमें एजिंग इज द मोस्ट इम्पॉर्टेंट इरिवर्सिबल रिस्क फैक्टर, और दूसरा है हमारी जीन्स। पर्टिकुलर रिस्क जीन्स होती हैं एपोई की, ये हम नहीं चेंज कर सकते हैं, पर जीन्स विल एक्सप्रेस ओनली इफ द एपिजेनेटिक्स इज फेवरेबल। तो उसके लिए बहुत इम्पोर्टेंट है कि हम जो है वो ब्लड प्रेशर, डायबिटीज को नियंत्रण में रखें। फिर स्मोकिंग, अल्कोहल, ओबिसिटी, ऑब्स्ट्रक्टिव स्लीप एपनिया, इसको न होने दें और न करें स्मोकिंग, अल्कोहल वगैरह। उसके अलावा जो फिजिकली एक्टिव रहें, सिडेंट्री एक जगह पे बैठना, पैसिव टीवी वॉचिंग, ये ना करें। वॉकिंग, एक्सरसाइज, योगा, नेटवर्किंग, सोशल नेटवर्किंग, वेदर लाफ्टर क्लब हो या योगा क्लब हो या even dance is known to prevent neurodegenerative diseases like Parkinson's, dementia, etc. Cycling, um, लर्निंग अ न्यू थिंग, नई भाषा सीख लें, जो आपको ना आती हो, नया कंप्यूटर प्रोग्राम सीख लें, या फिर माइंड एक्टिविटीज लाइक पजल्स, पेंटिंग, सुडोकू, ये सब करें। और अपने कम्युनिटी में इंटरेक्ट करें। पॉजिटिव एक्टिविटीज, सोशल एक्टिविटीज, स्पिरिचुअल एक्टिविटीज जो मन को शांति देती हों, वो करें। इसके अलावा कम्युनिकेशन, जैसे डॉक्टर विनय ने बार बार बताया, कम्युनिकेशन, अपने आप को आइसोलेट ना करें। दिस इज ऑल्सो प्रिवेंटिव। खाने में ये जरूरी है कि हम जो इंडियन ट्रेडिशनल फूड है, पर्टिकुलरली हल्दी, स्पाइसेस, लेस ऑफ ऑयल, सैचुरेटेड फैट्स न लें, ग्रीन्स, स्प्राउट्स ये लें, फ्रूट्स लें। नॉनवेज फूड न का सेवन न करें। अगर आपको नॉनवेज बहुत ही जरूरी है तो रेड मीट को कंप्लीटली अवॉइड करें। और जो हेल्दी ऑयल्स हैं जैसे मस्टर्ड ऑयल, ऑलिव ऑयल या थोड़ा बहुत घी, वो यूज करें। इसके अलावा बहुत जरूरी है कि हम जो हैं, अगर पर्पस ऑफ लाइफ, एक प्रिवेंटेबल प्रिवेंशन ये भी उभर के आया रिसर्च में। ओल्ड एज में या जैसे भी हम जितनी भी उम्र के हो, हमारा एक पर्पस ऑफ लाइफ होना चाहिए, which means that we should have small goals which are achievable. We should be able to help people out, और सेवा करना भी एक इम्पॉर्टेंट फैक्टर होता है, बिकॉज दैट गिव्स यू अ पर्पस ऑफ लाइफ। सो अलग अलग तरीके से ये सारी चीजों को अपनाएंगे तो बीमारी आएगी नहीं, क्योंकि आप एपिजेनेटिक फैक्टर्स को मॉडिफाई कर रहे हैं। बदकिस्मती से हम ऐसे शहर में रहते हैं जहां न चाहते हुए भी हम स्मोकिंग कर रहे हैं। हम पोल्यूशन, जो एनवायरनमेंट में है, उससे भी रिस्क फैक्टर डिमेंशिया का बढ़ता है। तो जितने भी लोग संपर्क रखते हो गवर्नमेंट से, गवर्नमेंट मशीनरी से, उनको बहुत जरूरी है, क्योंकि विदाउट पॉलिटिकल विल पावर, अगर आपकी जो पॉलिसी मेकर्स हैं और ये इनका विल पावर नहीं है ऐसी बीमारियों को रोकने का, तो ना पोल्यूशन में रोकथाम होगी, ना स्मोकिंग और सेल ऑफ सिगरेट की पॉलिसीज में रोकथाम होगी। तो इनका भी साथ में होना बहुत जरूरी है।
Thank you very much.
Very well.
Next question goes to Dr. A.K. Singh Saab. Sir, are you getting me?
Yeah.
Singh Saab, this is a particular question for you. How can digital tools, apps, or AI support doctors and patients in managing dementia better?
Digital tools in helping prevent dementia. First is, of course, one has to diagnose that dementia है कि नहीं है। उसके लिए भी digital tools available हैं, online apps हैं, which can allow you to assess your own cognitive status. पर प्रॉब्लम क्या है कि कॉग्निटिव स्टेटस को एग्जामिन करने के लिए जो apparatus है वो हमारा ब्रेन है, और अगर हमारा ब्रेन ऑलरेडी कॉग्निटिव डिक्लाइन में है तो फिर वो शायद असेस नहीं कर पाएगा। तो somebody else should assess it. One can get an idea, but assessment दूसरे से होना चाहिए, खुद नहीं करना चाहिए। टूल्स अवेलेबल हैं, but be careful about that, how to use them. Number two, how can you use them? There are many mental exercises which are available. जो पहले आप हम किताबों के रूप में देखते थे, वो आज के ज़माने में डिजिटल रूप में अवेलेबल है। You have things that you can remember, shapes that you can remember. You see a shape and then you try and draw it again. You read something, then you write it down. These are tools that are used for training the mind, that you do it for a child. Same thing has to be done. अगर किसी को कोई भी इम्पेयरमेंट है, फिजिकल है या मेंटल है, उसको बिल्डअप करने का एक ही तरीका है, यू हैव टू डू एक्सरसाइजेज, द रेलिवेंट एक्सरसाइजेज. For physical, it will have to be muscular exercises. For brain, it will have to be cognitive exercises, which include memory, memorizing shapes, naming objects, finding their functions, finding their interconnections. These are various tools that are available. AI would act as a kind of a sounding board. It can, the trouble is that AI can also cloud you. Because AI is not self-intelligent. It is made intelligible because of what algorithms we've written. So therefore, be careful about that. It can give you a sense of knowing because it will reflect whatever you're saying. You need to be able to challenge AI. Only then it becomes useful.
Thank you very much, sir. Sir, next question goes to Dr. B.S. Mehta, sir. Sir, very simple. Could you tell us, is dementia more common in certain age groups or gender? If yes, why? Please.
No, this has been, I think, greatly discussed. It is more common in the as the age advances because of several factors which every speaker has mentioned. That so, as Dr. Vinay Goyal said, you use your brain, remain active, and all the preventable causes have to be taken care of. It's not necessary that every age the brain has to get dementic. No, if you use your brain properly, you can be active at any age.
Thank you, sir, very much. And next question goes to Dr. Shefali Gulati. Dr. Gulati, Shefali Gulati, please. Hello, Dr. Shefali Gulati.
Yes, sir.
Yeah,
Yes, sir.
madam, could you tell us childhood dementia is very difficult to cure? What would you comment?
सर दोबारा बोलेंगे सर?
Childhood dementia is very difficult to treatment and cure. What would you say?
हाँ सर, वो because most of them are neurodegenerative conditions, तो उनको we have to pick up early and definitive treatment बहुत कम में है. So that is true, but we have to provide the multidisciplinary support and coping strategies to parents. And most of them, sir, जितना भी
Thank you
करते
very
हैं ना,
much.
if you are, most of them actually, sir, die within 9 years actually of diagnosis. तो भी जितना जल्दी होगा, as I was mentioning, जैसे adrenoleucocyte dystrophy है, जल्दी पिकअप करेंगे तो we can do a hematopoietic stem cell transplantation, तो वो ठीक हो जाते हैं बिल्कुल. तो मतलब that's why थोड़ी early recognition से होगा, पर ये कुछ कम लोग, कम percentage of conditions में ही ये.
Okay, thank you very much. Thank you very much. Sir, next question, last question goes to Dr. Arun Agarwal Sahab. Sir, you are expert and you are also medical advisor in clinical research and innovation. So this you could answer very easily. Sir, are there any Indian government initiatives or healthcare programs supporting dementia patients and caregivers?
देखिए तिवारी जी, वैसे तो गवर्नमेंट ऑफ इंडिया मेंटल हेल्थ पे बहुत काम कर रही है और मेंटल हेल्थ को लेके वो काफ़ी उसमें एक्टिविटीज चल रही हैं। लेकिन आज के डिस्कशन के बाद मुझे एक चीज़ लगी विच आई एम गोइंग टू शेयर विद ऑल माय कोलीग्स। दे आर डायरेक्टली इनडायरेक्टली दे हैव बीन एंड आर एसोसिएटेड विद डिपार्टमेंट ऑफ हेल्थ एंड फैमिली वेलफेयर। I think besides the entire mental health program going on, the way, if I use the term dementia, the overall prevalence of dementia in rural areas, which is perhaps increasing more than urban and women. So it's a question of women health also, it's a question of geriatric health, it's a question of longevity. Yet there are so many things which we are targeting. We are targeting longevity. We are talking quality of life, right? So all these things are important, and in pediatric age group also, government has to emphasize more and more about this condition, and that what I feel, तिवारी जी, हम सब एफर्ट्स करें और आपका मीडिया भी ये एफर्ट्स करे जितना ये आप राइटिंग में ला सकें या अपने विजुअल क्लूज लाइक जो आप कर रहे हैं कि इसकी इम्पोर्टेंस बताएं ताकि गवर्नमेंट भी इसको ज़्यादा से ज़्यादा ध्यान और दे इस पे।
Okay, sir.
बहुत
Thank
जरूरी।
you, sir. Now
बहुत जरूरी।
it is a time for you to conclude today webinar,
I
sir.
think we had a wonderful discussion. I would like to convey my sincere thanks to all my experts, Dr. A very special thanks to Dr. Mehta
Thank you. Thank you.
and Dr. A.K. Singh, Dr. Vinay, Dr. Shefali Gulati, Dr. Manjari. Thank you, Manjari, though you were in your hometown, but you could join, right? And Dr.
Thank you.
Sanjeev.
Thank you.
And I think you all agree that we this public health problem है उसको हम गवर्नमेंट को भी रियलाइज कराएं कि इसके लिए कुछ ऐसे इनिशिएटिव लें ताकि इसको हम प्रिवेंटिव एस्पेक्ट के एंगल से as during the discussion we have noted many points so that perhaps overall you cannot finish it, but overall incidence in future may also come down. Let us become, if Japan is an example, हम भी कुछ उससे और एक्स्ट्रा करके दिखाएं। हमारी इंटीग्रेटिव मेडिसिन में बहुत कुछ है, उसको समझना पड़ेगा, हमें हमें उसको स्टडी करना पड़ेगा एज ए डॉक्टर फ्रॉम मॉडर्न साइंस and perhaps combination of both may also give you futuristically good solution. तो थैंक यू वेरी मच तिवारी जी। एज यूजुअल डबल हेलिकल मैगजीन जो एक बहुत इम्पोर्टेंट मैगजीन है, बहुत अच्छे टॉपिक कवर करती है, उसके लिए आपने ये टॉपिक चुना और उसको आप पब्लिश भी करेंगे विद आर्टिकल्स टू बी गिवन बाय all the expert in front of you and me. Thank you and remain safe, healthy, and we'll meet again. Bye for now.
Thank you very much, sir. Thank you,
Thank you.
Dr.
Namaste.
Singh.
Namaste. Thank you.